Hi, welcome to the third edition of the Education Exchange in partnership with the SDMS and GE HealthCare Ultrasound. Thanks so much for joining. Today, we're going to talk MSK or Musculoskeletal Ultrasound, and we have a phenomenal physician out of Wisconsin that is joining us today, Dr. Humberto Rosas, who I've known for several years. I'm sure if you've gone to any of the big shows and dove into the MSK world, you've seen him speak or some of his work as well. So thank you so much, Dr. Rosas, for joining us today. I'll turn it over to you and tell us a little bit about yourself, where you're at now, and maybe a little bit about how you got here. Not here. I suckered you into here, but how you got to this point of your kind of MSK journey.
Of course. Well, I'm an MSK radiologist. I actually started off as a neurosurgeon, surprisingly, and then saw the light, went to switch into radiology and fell in love with MSK. My ultrasound experience actually started with Bill Middleton about 30 years ago. I was a resident. I'm kind of dating myself. And he was one of the first people to look at shoulder rotator cuff tears back in like the late 80s, early 90s. And that just sort of caught my imagination. I was just sort of all of a sudden was enamored and found it to be exquisitely amazing that he was able to see the cuff in such detail. And, he started doing some of the early work when MSK ultrasound really wasn't that popular. And from there, I just sort of kept kind of chipping away and trying to learn as much as I could. And then ultimately, almost 30 years later, I'm now here sitting with you talking about MSK, which is become a lot more frontline imaging than it was back at that time.
Yeah, even 10 years ago. I think all specialties event or essentially start or historically start from grassroots, but I feel like MSK really was this and is still this grassroots effort, even though, it's becoming more mainstream. I still see the struggle in kind of really putting in the time and the work. I know your story and I know how you literally taught yourself. But I think that's really interesting if you could share with sonographers. I think the hard thing about MSK is finding what you're looking at because they're so small. And the resources out there are numerous now compared to 10 years ago. But when you talk 30 years ago, how do you even begin? How do you even begin to kind of pave or pioneer that kind of movement for yourself?
Yeah, back then, you're right. There weren't textbooks. There definitely wasn't anything online, no YouTube or TikTok videos for us to sort of kind of figure out where we were or what we were doing. There weren't even actual classes you could go to, or any of the conferences weren't really actually showing MSK ultrasound. In fact, I would say John Jacobson was the person who really pushed having ultrasound at some of the early conferences in MSK where no one was actually, lecturing or doing a lot of work on MSK. For me, I started with a Netter book and I just kind of plopped it open. And at the time, we had finally gotten an 8-tail ultrasound. You probably remember.
I
It looked kind of like a aircraft with 1,000 buttons. And we thought it was the best thing that had ever been made because the quality of the imaging was so exquisite for us at the time. So I sat there probably every night with a Netter book and I started imaging myself and trying to kind of mirror what I saw in the Netter books with my basic knowledge from MRI and kind of medical school, and then trying to sort of map out tendons and ligaments and muscles, slowly trying to figure out what was the best window to kind of visualize these things. And then as I started feeling a little bit better, when patients would come in for any MSK ultrasound, if I felt not so good about another area, I used to, if I was doing a shoulder and I didn't feel great with the ankle, I would actually ask and say, hey, I'm just learning how to do this. It's pretty novel. Would you be okay if I sort of just scanned your ankle sort of on the side for free? And funny enough, most people would be like, I have a little bit of ankle pain. That would be great. Why don't you take a look? So then I would go and I'd try to look at certain structures and see if I could find the same things I was finding on myself on other patients. And now and then you'd find, what the cause of their pain or discomfort was in these other areas. So that's sort of how I started getting the experience. First, kind of imaging myself. Back then, I was the normal findings. Now, if I image myself on the pathologic slides that I show at many of the conferences, and then just kind of practicing over and over again on patients. And I still do, I go in almost every patient that I do an ultrasound, just mainly to see if I could see some other detail. Ultrasound now has such exquisite resolution. We're starting to see some very small ligaments and nerves and things that we hadn't in the past. So sometimes if there's something that I wonder if I can see this, I'll go in and still do that. But I also go in diagnostically just so that I can maintain my skills, because it's one of those things that you need to do it, over and over again constantly. So I think that's how I started off. I think now with a lot of the conferences, I think there's a lot of mentorship and also an ability to figure out how to navigate the waters. It is sort of time consuming, but once you feel comfortable with it, I think most people just love it.
Yeah. It's interesting you talk about Netter. So that's how I got into MSK too, is it was new. They needed someone, the school I was, associated with needed someone to write a book on it. And I had taught anatomy. They're like, that's the biggest hurdle. So you're into it. And that really, when there's sonographers who are first interested in MSK, I'm like, the first battle really is the anatomy. Once you know the anatomy and kind of where you're looking at, and you can find those origins and those insertions, things kind of come into view. But until you kind of have that solid anatomy, and then as you said, practice. I mean, still to your point, I work some of the lectures that you're at, and Dr. Van Holsbeek will go after a nerve and he's like, you see what I'm looking at? I'm like, I really don't. I don't. I look at this nerve twice a year with you, Dr. Van Holsbeek, and this is that weekend. I need a little refresher on it. So, but it's just retraining that eye, because there's such subtlety in the areas that you're looking for, and teeny tiny structures, but we are able to see so much more. You talk about learning on the shoulder, and that's the most common origin point. I'm curious to hear your answer to this, but when people ask me what do we image with MSK, the answer is more what don't we image with MSK. How do you feel about where we've come now from, we were kind of rotator cuffs and wrists, and where we're at now in the
Yeah,
industry?
I love that question. I also love your answer, which is sort of kind of how I feel. Like, what don't we image, or what won't we image, right? Like, we'll image pretty much anything. Yeah, I think we've migrated from tendons and ligaments, sort of bursa and joint effusions. That's sort of the mainstay of what we do day to day in daily practice and what we've been doing for the past 20 years. I think now we've evolved more into nerves, small peripheral nerves, looking for impingement or even small neuromas or tiny little areas of entrapment. I also think that it's become sort of ubiquitous in doing procedural work, minimally invasive work, whether it be injections into tendons and ligaments with stem cells or PRP, or whether it's little ablations. We're starting to ablate a lot of these smaller nerves like the geniculate nerves, and you can see it with exquisite detail with ultrasound. So I think it's pushing the envelope on some of the interventional procedures that we can do at the bedside, minimally invasive. And I think it's just going to kind of continue to expand in terms of what we're doing. I also think it's going to expand, it's expanded into sports, as you know, in the sports clinics, point of care clinics, rheumatology clinics, emergency room. I foresee that you'll start seeing this also in primary care physicians more and more when they're dealing with MSK kind of problems with our aging population. It's pretty common for people to come in with sort of aches and pains, and people don't really want to wait for an MRI for 2 months anymore, 3 months. This is going to sort of expedite patient care. So I also see it as a way of kind of improving patient care, also kind of getting the care expeditiously rather than waiting for months to get an answer. So I see it in multiple ways, sort of evolving, not just in what we do see, but how we use it and where we use it as well.
Yeah. I know when I started, I'm not saying 30 years, but it's not that much less than that. Mobility. We talk about the mobility of the joints, and when we talk about CT and MR, the motion artifact in those is pretty prevalent, and pretty much ruins the study, if not totally ruins the study. But a lot of our patient base, the pain is in the movement. How has the addition of ultrasound, not only in those cases, and my pain is when I do this, but to your point, kind of the open broadness of the patient spectrum, how do you see that affecting patient care? How have you seen that affecting patient care?
Yeah, dynamic ultrasound is sort of key. I look at ultrasound and MRI as sort of complementary imaging modalities, not necessarily competitive, but more complementary. But dynamic ultrasound is sort of the one thing that I think is a major advantage with the ultrasound. Where I've seen it is twofold. One, often there are patients who come in with like a painful mass, they get an MRI, really don't see anything. No one knows what to do because the patient is fairly confident that there's a mass somewhere. In those cases, I've often found the mass, and it almost always ends up being like a muscle herniation. And the only time you can see it is if they're sort of putting force contraction on that muscle. You'll see it kind of extend through that fascial plane, and then you'll see this mass. And sometimes they're actually quite big. You're almost surprised at the size of those. So in that case, you get an answer. You also determine why they have pain, and there are treatments for that, most of them ending up being surgery. So, this is one huge advantage there. The other one is sort of clicks and clunks, where somebody feels a snap or a pop. They can't figure out what it is. Again, the MRI usually will look normal because it's often either a tendon
Yeah.
or a ligament that's snapping. It's not necessarily tendinopathic or have any evidence of partial tearing on MRI. So you get the ultrasound and then you actually determine what's actually snapping. And sometimes it can be something, vitally important, even like peroneal nerves that can kind of snap within their tendon sheath, can be exquisitely painful. Again, that may lead to a surgical correction for the patient. But if you're not sure where it is, or they can't always elicit it kind of in clinic, having that dynamic ultrasound is vital to these diagnostic, dilemmas. So I find it to be super helpful in those particular clinical scenarios. Yeah, 100%.
Yeah, I think where we've come and where we're going in all of ultrasound, right? Just ultrasound in general, but I really see MSK, every week, every other week, there's some new conversation coming of, have you heard someone doing this or using this, or have you read this article? And for me, that's really exciting. But it's also a little scary in terms of I like to give radiologists a hard time. I give you a hard time. There's reasons for it. But, when we talk about what we saw 30 years ago on ultrasound versus what we saw 25, 20, 15, 10 now, how do you as a physician, because this is as a sonographer, I would assume most of this sonographers listening to this is probably one of our biggest learning hurdles too, is what's normal every time we see more, for instance, the bursa, right? The bursa used to be the fallopian tube. If you see it, it's abnormal. Now we see every bursa. How do you as a physician, how have you as a physician in your tenure addressed that continual learning curve, especially in a modality that's not MR, right? There aren't textbooks. How do you address that?
That's a excellent question. When I finished my training, there was a MSK radiologist. His name is David Rubin. For me, he's like the Michael Jordan of MSK radiology. I love him to death. He still works, and I still talk to him often, actually, for mentorship. He was my faculty for a long time, and I asked him before I was finished. I said, "Hey, what I want to know is, how do I become an exceptional MSK radiologist?" Because I really thought he was just so phenomenal at sort of every aspect of the field that I just was enamored with the guy, right? Like he like walked on water for me. And I said, I just want to understand what I need to do over the next, 10, 15, 20, 30 years. And he said something so simple, which at the time didn't resonate until much later in my career. And after you asked me this question, was the most important thing to be an exceptional radiologist or MSK radiologist is to understand what normal is and what it looks like. And there's a lot of subtlety to that comment, right? Like it seems like, well, of course I know what normal is, right? The tendon's intact. Of course it's normal. But sometimes there's tendons that have weird anatomic variations. There might be a tendon that 10% of the time splits. You call it a split tear on accident, and you gave the patient pathology when actually it's normal, right? Or other little things, that you just have to have experience with. And I would say the most important thing is to do a ton of scanning. Just like the more scanning you do, the more obvious normal becomes. I think also if you have someone with a little bit of experience and you see something a little funny, it's always good to take the picture and then ask, like, hey, have you seen this before? Can this be something normal or is this something, abnormal? And I know when I first started, we couldn't see, like we look at the first extensor compartment a lot, right? A lot of people have De Quervain veins, super common now because everyone's on their phone and using their thumbs for all kinds of activities. Like it was already common amongst people who use their hands quite a bit, but now like I see it probably weekly versus maybe every other month. And when we first started, those tendons all looked like single slips. And over time, ultrasound got better. And all of a sudden, we were seeing multiple slips of the abductor pollicis longus. And we were like, is that split tears? And then we realized, oh my God, there's like 5 of them. And then we realized, you know what? There are multiple slips in like 70+% of patients, right? We just didn't have that exquisite detail. And in fact, on MRI, it looked sort of like one tendon, but right over time, we realized, well, everybody can have 6 tendon split tears, right, in one tendon. So we finally acclimated to the fact that that was a normal finding, right? And so I think over time, especially with the exquisite detail we're getting with these high frequency probes, you're starting to realize what's normal and what's not normal. And I've had to acclimate my eye. Your hockey stick, your compact linear is exquisite. I mean, ridiculous, right? And I remember the first time I used it, when I looked at some of the tendons, like even like the peroneal tendons, you started seeing fibers that you couldn't see before, like an exquisite detail, and you would almost see little slips, and you're like, is that a little tear? And then you'd realize, you know what? It's not a tear. I'm just seeing the fibrils so well that this is kind of my new normal. So I ended up again going back to myself and sort of looking at all my tendons when I got that new curvilinear linear, and I just started scanning myself so I could determine what I felt was normal and what I felt was abnormal. And I had to just reacclimate my eye a little bit. And I think that's kind of the best way of doing it. And what you said is kind of 100% correct. You have to understand normal to understand what's abnormal. And it's just going to take experience and sort of understanding how to evolve with the new technology and this exquisite detail that we're getting now.
Yeah. I think you brought up a good point with the fibrils of the tendons. I think for me that was key in learning MSK was going back down to the histology and knowing the fibular arrangement of a tendon versus a ligament versus a nerve, and then being able to equate that in what you're seeing, because you truly can when you go cross, and even not cross, even in long, but when you go transverse, you really can see every little peg. And when you go on the nerve to understand why it's that honeycomb, and what those kind of, almost fat bumpers in that nerve do, and just bringing it back down to the histology to that point of, are all these tiny lines I'm seeing, like, is this slips? Is this shredded? What's going on? Versus, no, that's true cellular level histology that we're seeing. I think that's a huge, again, learning curve, because we don't see that in liver and we don't see that in the solid organs that we're used to. But again, just reequating back to normal, but that new normal curve gets yanked about every 2 years.
Yeah.
There's, something new, and it's not even necessarily equipment wise, it's someone pushed the envelope, one further. I just reread Dr. Solomon's article on prediabetes and MSK ultrasound. Phenomenal article, but would I have ever put 2 and 2 together? Absolutely not. And now we're talking elastography and
Mhm.
quality of reattachment and surgery. The things, the professional associations are asking us about their athletes and how they're approaching not only the initial diagnosis, right? Go Chiefs. Pat comes off the just small plug here. Go Chiefs. Pat comes off the field, high ankle sprain. The fact that they can look at it there, decide there, what's going on, where best to tape him, where best to brace him, do we risk it? Those are decisions that 10 years ago were clinical decisions rather than informed decisions. I know you saw that at the University of Wisconsin. Did you see that decision pattern change a little bit on the
Yeah,
clinical side as well?
it's completely starting to change. Initially ultrasound for MSK was sort of diagnostic.
Yeah.
And I see now that it's going to sort of try to be a little more predictive or determine like return to play for a lot of these players. It wasn't something we were doing much of. It was most things were based on clinical or just how the patient was feeling, right? I'm feeling better, so we're going to go ahead and push things. But with elite athletes, at least currently, we're doing more and more ultrasound to see if their improvement and gains physically in terms of less pain relief and ability to increase, how much stress they're putting on their muscles and tendons, if that actually translates to what we are seeing with ultrasound. And I think that there's going to be a new paradigm where you're going to have to meet certain kind of imaging landmarks like this. These are the protocols where when your muscle looks like this is when you can return to play, or when your tendon gets to this point, you can return to play. Elastography is one of those areas that's going to help, especially to see, what the kind of tension on these tendons looks like. How stiff are they? How non-stiff are they? Are the areas of injury actually improving? Are we seeing changes also in elastography? That's sort of in its infancy right now, but that's sort of where it's going to go. I mean, I can foresee probably hopefully I'll be retired by this point, but probably in about 15, 20 years, I could actually even see sort of a thin wearable kind of integrated ultrasound within the clothing of an elite athlete, where it will be able to actually detect changes in many of the tendons, particularly superficial tendons like patellar tendons, quadriceps tendons, those kinds of things, and then determine if they need to actually be shut down for a couple of days or if they can actually push things a little bit harder. And I think that's somewhere where ultrasound is going to go. It's the only modality where you could probably do something like that with those dynamic, capabilities. I think it would be pretty awesome. It's one of the things that I always wanted to do. We played around with making sort of a wraparound ultrasound for the knee at one point, just to look at how the tendons kind of worked after someone had some repairs while they were running on a treadmill. And we made sort of a kind of Frankenstein kind of thing with multiple probes, but it was pretty amazing to watch in real time because you could actually see the tendon stretching. You could see that some areas of tendinosis were stiffer than others, and so those kinds of things are where the future is going to go. And now with so many elite athletes, I mean, college athletics is not what it was 20 years either. I mean, they're essentially professional athletes, and
Yeah.
so understanding also our young college athletes and determining also for them when it's time for them to return to play or if they're becoming injured from overuse is going to be key. So I think that's kind of where the future is for MSK a bit.
Do you see elastography used as like a baseline? So they come into we'll use NFL, they come into the combine, we do an elastography baseline to see where their tendons are and then chart that data, or do you see it more as like point in time, as needed type technology?
Yeah, I think every place is a little bit different in how they're using it. So there are some teams that are using it, preseason before things get going, and then kind of doing serial ones throughout the season. Others are sort of using it more point of care when there's an injury to kind of determine if they can see changes with, the rehab process. So I think once more and more of that data, the NFL has a ton of grants, which is great to allow this kind of research. And I think once some of that stuff is a little more elucidated, then teams will probably adopt early evaluation a little bit more than just waiting until there's an injury or someone's complaining about some kind of pain in one of the tendons or ligaments. So I foresee that the NFL, NHL, all of the professional sports are going to probably be using MSK ultrasound and likely either elastography or something similar to elastography kind of throughout the season. That's what I foresee. It's not being used in that manner very much currently, but I think that's where the trend's going to go.
Yeah. And I think, you talk about your Frankenstein, but I don't think we're that far off as an industry. We have cordless transducers. The way we manufacture our like crystals now, they're much more synthetic than they are organic. Historically, we're gonna have the ability to build that kind of even more mobile, wearable technology is what I foresee. If I had to make a wish list of dreams, and I don't think it's just athletes. I think it's, our professional athletes. I think to your point, we're starting kids in athletics younger and younger and younger. The more studies we can have about the stress and strain and what's going on, but also older in life, is what's the quality of Mima and reattaching Mima's shoulder, which I don't recommend. Please don't do it. It's terrible. But like what's that risk, what's that risk outweigh, what's that risk benefit? And even the pre-diabetes work that's being done out there, we're finding out so much more, again, down to the cellular level, where we can start to have those predictions. And for me, that's really exciting, beyond
Yeah.
just injury.
Yeah,
Yeah.
a lot of people, even for, elderly patients, are looking at sarcopenia. So they're looking at muscle bulk and just determining how they can increase it, because it's been shown to have a major, it's a major prognostic indicator of how a patient's going to do in terms of like how their knee's going to feel, how your back is. It's been shown with back pain, so how can we get those muscles to sort of increase in size and things? And those are things that are simple to look at under ultrasound. I think the first iteration will probably be a even smaller pocket ultrasound, where you can just kind of slip it into your pocket and then have it in pretty much every clinic, so that you can do some ultrasound. Yeah, I mean, your handheld is getting pretty close. It's pretty good, but I'm talking like a thin, like smaller than
Peonies.
an
All
iPhone,
right. All right. You're getting
kind of
greedy.
thing. I,
You're
I
getting
think
greedy.
that'll be next. That's going to probably be coming because it's getting smaller. But yeah, no, I mean, if you think about the technology, it's really quite incredible. Again, I'm going to be dating myself here, but I remember when I was a teenager, my phone was on a wall and it had a cord on it, and you didn't really know who was going to be
Nope.
calling on the other line, right? The phone rang, you had no clue who was on the other side of that line until you picked it up. And that's actually kind of awesome in one sense, because the surprise was kind of nice, right? The spontaneity was fun. But I remember when the first cordless phone came out, I felt like it was, I understood the technology, I understood the science, but still it was somewhat magical. It was almost mystical that you could walk around your house with it. And then when the cell phone came out, even more amazing, right? The technology is almost like, for someone my age, it's quite incredible. It's like an airplane for my grandparents, right? When they
Mhm.
saw the first airplanes, thinking, "Oh my, I can't believe someone can fly." I felt the same way when I started seeing the portable ultrasounds, these small
Yeah.
ultrasounds, where you're getting this exquisite detail with a little probe that's about this big, that's wireless. The amount of data that's being transferred is quite amazing. And for me to be able to do that real time and get images and be able to do it with a small ultrasound, and actually, even having two heads, right, one on each side, where you
Mhm.
can have a curve on one side and a linear on the other. That's really, to me, sort of magical. And it kind of brought me back when I first saw it to when I saw the cordless phone and then the cell phone, where I was like, it's quite incredible where we've come in what I consider a pretty short amount of time, if you really think about it. And that's going to make it much easier to get ultrasound in every clinic. I think that's why we're seeing it. I think that's why you're seeing MSK ultrasound. Before it used to be in the hands of MSK radiologists, right? Like, I don't remember any other clinic doing MSK ultrasound about 20 years ago. If you needed an MSK ultrasound, you pretty much came to an academic center like mine. There were actually only a handful of academic centers that were even doing a high number of MSK ultrasounds, and now it's in orthopedic clinics, sports clinics, rheumatology clinics, ERs, point of care clinics. And now that we're starting to see like wellness clinics and longevity clinics, I'm going to foresee that they're going to be in those clinics. And where I hope I get to see it in the next couple of years is in PT and rehab. It's in sports, but it's not as much in PT and rehab. And I think our, physical therapists and rehab providers, I think they're going to get a huge amount of information if they can use it in conjunction with all the physical therapy that their patients are going through. And now, with these smaller handheld ultrasound probes, I think it's going to be a lot easier to get them into these clinics, right? You don't have this huge, cart that you have to move around or shift around. You just have this small little handheld ultrasound probe. It's quite impressive and exquisite. Those engineers are quite incredible in what they do. So yeah,
Yeah,
no, I agree with it.
I literally fly with mine. It's like a sunglass case.
Yeah.
TSA loves me. I always have something fun. in my bag when I'm coming back from the office. But yeah, it's I mean, it just looks like a sunglass case. But to your point, that's the first rendition of where we've gone cordless. When we look at our corded probes, how small we've gotten them, what's that future look like and what's that applicability? Can get it on your personal phone. That's huge. It's amazing to me. Um, Candidly, why I picked this modality personally. And now I'm going to get you in trouble because I'm going to ask you as a physician to just compare and contrast a little bit. As a physician with a history in neuro and then MSK, when we look at the spectrum of imaging, obviously everything has their place, but we see greater advances in some areas like MR and ultrasound. How do you weigh and sort as a physician those different imaging kind of modalities and pathways that are available in terms of limitations or successes or challenges for kind of what we're looking at in today's age?
I mean, nowadays you have to weigh one major thing where I think ultrasound has an advantage is how cost effective something is, right? Ultrasound is a lot more cost effective than MRI or CT by a fairly large margin, right? So I think that adoption of MSK ultrasound is key, especially when it comes to looking at tendons and ligaments. And when you're looking at the rotator cuff, anyone over the age of 50 honestly probably should be getting an ultrasound. There's advantages to it. One, it's as accurate as an MRI. Two, once you get into my age group, you're not worried about a labral tear. You're really worried about a rotator cuff injury. So that's where the money is, right? So that's where you need to be looking. So it's just as accurate. Um, Patients tend to actually prefer an MSK shoulder ultrasound over an MRI. I think partly because when we go in, we sort of tell them right off the bat, this is what you have. So they get sort of this immediate answer to what's ailing them. Like, why has my shoulder been killing me for 2 months? You might see calcific tendonitis, or you might also, see a rotator cuff injury. It could be a gamut of things, but they get an answer kind of right off the bat. The other advantage that I have, is because I have a procedural service. If you diagnose something that you think you can treat, the patient doesn't have to make another appointment, so you can sort of go ahead and treat it, right? So if they have calcific tendonitis, you might be able to lavage it, remove the calcium, do a quick bursal injection to help with the post-procedural pain. And so they got the diagnosis and the treatment all in one setting, and then go home and are really happy with that encounter because it was sort of very efficient for them, right? There isn't multiple trips back and forth. You're not calling scheduling 100 times. So I find that ultrasound sort of that's where it sort of shines. That's where I think it has all the advantages over other modalities. I think where MRI comes to play, I would say the one advantage of MRI, to play devil's advocate, obviously, we're talking about ultrasound and I'm shining a spotlight on it. I think the one place where MRI might shine is sometimes you get a case where nobody really knows what's going on. It doesn't really match one particular thing or one particular area. So they may have shoulder pain, but it doesn't seem like it's isolated to the cuff or the joint or one other area, and you don't know really what's going on. The one nice thing about MRI is the field of view is large, right?
Mhm.
So if you are in a conundrum and things just don't match up clinically, where you sort of have an idea of where you want to center or focus your time, I think MRI is advantageous in getting a large field of view. And so I think that's where maybe MRI has a slight advantage. But if you know that, oh, it's primarily around the shoulder or the ankle or in this particular area, I think ultrasound does a great job. As you know, we can't get through the bones, right? Not yet. There's someone working on a way to actually see through the
Hmm.
bones with ultrasound, which I found to be quite amazing. They sort of use a bunch of reflective patterns to go around a bone and have it kind of reflect back. Quite exquisite work this person I know is doing. But until we get to that point, there's certain things we can't see, right? So like I can't see parts of the labrum as well. I can see most of the brachial plexus, but the clavicle blocks a little bit of it. So you're sort of digging around, trying to get around as best you can, right? So there's some areas
Yeah.
like those that make MRI a little bit advantageous because you're not obviously getting obscured by the osseous anatomy that's surrounding the area. But in general, MSK ultrasound is advantageous because how quick it is, cost effective it is, And especially as we talked about already, that dynamic imaging is sort of key, especially when looking at tendons and ligaments. So they both have advantages in different ways. Um, with both kind of having their own kind of role to play when it comes to musculoskeletal pathology. But there are a huge number of advantages where it comes there. Ultrasound, I think, kind of shines a little bit more than MRI, and I personally think I mean, I love it. I think early adoption was hard, as you know, because it takes some technical expertise to get facile at doing it. And so, but once you get over that hurdle, I think you end up, I recommend ultrasounds often when I'm doing an MRI, which is
Yeah.
kind of interesting if you think about it.
Mhm.
But often I'll say, I think you should get an ultrasound for better evaluation of certain things that I see. Sometimes I recommend a dynamic ultrasound. Sometimes I'll see something and I think, you know what, I have a bad feeling that this tendon is probably subluxing or dislocating. I think you should do a dynamic ultrasound to evaluate for that, which can be a source of pain. There's a lot of little areas where I actually recommend an ultrasound, which I probably never did 20 years ago.
Mhm.
But now you know what the role of ultrasound is, and so you're starting to divert some of the patients in that way. Or if you get a call and someone says, "Hey, I'm specifically looking for X, Y, and Z,"
Yeah.
often you're going to say, you know what, you really want to get an ultrasound for that because of the dynamic capability of ultrasound. This is going to help answer that specific question that you have. So again, I'm not throwing shade on any of the
Yeah.
modalities. I'm just saying that there are some major advantages to both.
Yeah. No, and I think that's a very fair assessment. We're good at ultrasound, but there's still physics, right? You can't, I don't know who your magician is, but you can't get, or I have suspicions, but you can't get around physics. Physics for now are still physics, and that speed of sound through bone is so much higher than everything else that it just kind of, to do one thing and not do the others is kind of the balance that we're stuck with now. And I think field of view, for me, also some of the 3D capabilities of MR, we don't always have a straight, complete tear. They're not always clearing, and I've totally forgot the NFL player, but a couple of weeks ago, I mean, you just watched that Achilles snap all the way and it just coiled all the way up. Um, we don't always have, that beauty of it being the perfect tear in the perfect location and not surrounded by osseous structures. And so there are definite, I don't think anyone would sit here and be naive to say that MR doesn't have its place, but I've definitely seen more and more navigating towards that ultrasound. And to your point, when they know where their pain is and when their pain is, it's a I don't want to say a guarantee, but it's, more times than not, you're going to be able to pinpoint it very quickly, give them the answer that they're looking for, and move them along in their pathway of care rather than, negating and waiting longer and risking further injury, which is always, we want to treat it minimally rather than worst case scenario.
Correct.
But yeah, so no, I think that's a fair assessment. So as we kind of wind down here our last 15 minutes, um, let's talk a little bit about the future of ultrasound. I think to talk the future, we a little bit have to reminisce on, again, the past of where we've come and, the applications we're seeing. I think one big thing is you don't see a future of a specialty. One thing I kind of want to talk about before we get there is you don't see a future of a specialty without seeing interest in the specialty. So for me, I hear sonographers that get more and more interested in our classes in Wisconsin. I think every year we have a few more that are interested, but are you seeing more on the resident and fellow end too? I will say, at our shows, the MSK, when we go to RSNA and AIUM, the MSK courses are more popular than anything. Are you seeing that same interest in kind of the radiology general fellows that are coming out?
Yeah, I think for fellowships specifically, most of the residents coming out when they're looking for fellowships are actually looking for MSK fellowships that have ultrasound training.
Mhm.
Because it's somewhat expected now, especially if you're going to work for any group that sends MSK patients. So anybody who's dealing with an orthopedic clinic or sports medicine clinic, if they don't have their own people doing it, then they expect their radiology team to be able to do it.
Yeah.
As you know, and I'm waiting for the day that this happens, you know, it's not part of the curriculum in the sonography schools, which I find kind of surprising currently. Like
Yeah.
in terms of future, a very simple thing to do, I think, would be to get this to be a part of the curriculum. I actually, funny enough, have even offered to teach and do a curriculum at some of the sonography schools, and they're like, well, it's not really part of the curriculum, so we don't really need that. And I've offered to do this for free because I would love to see more and more of our young sonographers be interested. And I think they do once they get out, and if the location that they work at actually does MSK ultrasound, you see that the young sonographers are super interested because it's a new skill that they can learn on top of everything else that they've learned in school. But it's not part of the curriculum, and I don't know how to push it. You know, I think that it's something that I hope in the next couple years becomes adopted, you know. And I think it's going to take like one or two of the larger sonography schools to do it, where people are like, you know, they're giving MSK ultrasound course as part of the curriculum now, because I think that that sort of helps to kind of spur interest once you get out. And also, I think it makes you more marketable also as a sonographer, right? Because there are a lot of groups looking for people who have that kind of training. I know when we train our sonographers, a lot of them get stolen for their MSK experience, right? Some group is like, we really need someone who's really phenomenal at MSK, and so they sort of steal these people who have like 5 to 7 years experience of doing high-end MSK imaging. So I think first and foremost, I would love to see that occur. For
Yeah.
our fellows, you know, our residents sort of have their own curriculum, and part of it, at least at UW and in most places, because it's part of their board's exam, do MSK ultrasound. So they're required at least to do a month. But where I see the most interest is people coming out and wanting to do an MSK fellowship. They're looking for an MSK driven, high, you know, high volume ultrasound service on top of doing MRI and other procedures. But, you know, in terms of the procedural side, diagnostic side, you know, ultrasound is every year kind of increasing in volume to the, you know, to the point that no one knows even know what to do because there's so many cases coming in, especially from the procedural side. Just because, you know, the literature has shown that it's pretty accurate, right? You can see where your needle's going, you can target a certain area. You know, patients are pretty happy. They don't like when maybe a blind injection doesn't work because then they have to go back and then they also have to wait, right? Because you can give steroids only so often. So if you're getting like a steroid injection, having that improved accuracy with you know image guided injections is sort of big. So I think that's where I see the interest. I see the interest though in other fellowships outside of radiologists, right? Like outside of radiology, you know, sports medicine now it's required in the sports medicine fellowship that they provide ultrasound training for the sports medicine fellow, right? This was not something that they required, you know, 15 years ago, but now it's part of the curriculum. I'm seeing it more and more in the rheumatology curriculum as well as the ED residency. So it's not just radiology residents that I'm sort of seeing this kind of bump in interest. I'm seeing it sort of across specialties, to be honest. And so you know, I'm glad because I think it's just going to make it something that you can get almost anywhere, right? Is it great for my career? Probably not, right? Probably it's starting to get less and less in the hands of a radiologist and more in the hands of people outside of my specialty. But I think that's wonderful. I mean, I honestly think it's great because if we can provide quicker and better care to all of our patients, that's essentially why all of us went into the medical field. You know, all of us, whether it be sonographers, physicians, physical therapists, rehab doctors, we all went in because we want to make people feel better. We want to get them, if they're in a sport or whatever activity they're doing, we want to get them back to the activities that they love to do, no matter what the age is, right? You know, I have a 95-year-old yoga instructor who needed to get an injection because they were having trouble getting into a particular yoga position and it was killing them. So, right, I got them back to teaching their classes. It was like a huge deal for them. And right, that is a humongous thing for quality of life. If you can do the things that you love, especially in activity, you want to continue doing that for as long as you can. And that's sort of part of why we do what we do. So I am super thrilled that it's being adopted by multiple specialties. And hopefully that'll just make it so much more available
Yeah.
for our patients. So, I mean, that's kind of how I look at it. So I see the interest, but I also see it outside of radiology as well.
I don't see you being replaced. Not until I'll let you retire first. First of all, I will still keep bugging you until then. But I think that's a good point. And I think, where we talk about point of care versus musculoskeletal radiology, for me, that's where I've seen the separation is point of care is kind of that quick answer where, you and the other kind of atmosphere of MSK trained radiologists are more comprehensive and to that totality of point. Is it torn? Is it not torn? Is a point of care decision? Is there fluid? Is there not fluid? But then deciding what else is there, isn't there? And I'm not saying they're not going to get there, but in the courses and the workshops and the things that I've been privileged to be a part of, they're not at the point of learning it all. They're still they'll get there. But I think in terms of the comprehensive, which I think is still exciting for me to advance both sides, because musculoskeletal radiology is not stopping at any point. That comprehensive exam continues to be more comprehensive and push forward more, where the other modalities, yes, and specialties, yes, they're coming along, but they're still 10 years plus behind. So I think there's always going to be that gap. But to your point, where I see it is that continuum of care. We have the initial decision into kind of, the information gathering back to kind of that full circle, rather than more of those gaps in the care. I think that for me is kind of where I see ultrasound playing in, is bridging those gaps between kind of that initial and furthermore. So I think that's interesting.
I
What
agree.
else future wise? I think you
I,
nailed it with the wearable ultrasound. I'm gonna go call my engineers now.
Yeah, wearable is going to be, I mean, wearable ultrasound would be so awesome. I need one right now. Everything hurts all the time. I would
Yeah,
love a
man.
wearable ultrasound. Be like, yep, that's what's going on. But I think AI is going to be something that probably is a topic that everyone's on everyone's mind, right? Is it going to replace us? What's going on? I think there's a lot of uncertainty with AI. I actually think AI is going to be a great tool for ultrasound. Where I see it initially is as a way to sort of make us all more efficient, right?
Yeah.
Do I really need to make a circle around every nerve to get a cross-sectional area? No, AI can make it and just pop out my cross-sectional area. In fact, it could make it and then just pop it right into my canned report so that it'd be really quick and easy. Does it have to, all these measurements that I make, AI can make those measurements, we're starting to see that in MR, we're starting to see that in ultrasound. So I think like things such as automated measurements are going to be key in terms of helping kind of expedite or helping identify anatomy in the future. I could see AI helping with that, right? Like if someone's a novice and they're in a certain area, it could maybe identify, oh, there's the clavicle. You know what? You just get move a little lateral, move a little down. It might actually be able to help with training purposes in the future. I completely see AI doing that. I think pathology wise, it'll probably help detect pathology well and be a secondary check at some point, as well. If you could make like a big patch or a wearable, then obviously that's when AI might be able to make a little more diagnostic kind of calls that it couldn't do. And that's when you start getting a little more nervous about, what's your role. But I think AI is also going to be coming into play. We're seeing it in ultrasound and DR and MR and CT. It's sort of across the board, and I think it can make things a lot more efficient. And even little things like, oh, it knows you're looking at the supraspinatus, so it just labels everything: supraspinatus, infraspinatus, teres. Like you're not typing anything, even though you guys are great because you have you can hit your button really quickly, right? But if you think about it, every time I hit a button, that's time, and we're at an age in the healthcare industry where everything's expected to be very timely. The volumes that I've seen like now compared to 10 years ago are quite tremendous. And, unfortunately for healthcare, and this is a whole other policy topic that probably we need 2, 3 hours to talk about. But as you know, right, in general, they tend to decrease the professional and technical fees for a lot of the modalities, MR, ultrasound, CT, across the board. And so, like, if you look over the last 20 years and you account for inflation, there's been sort of a 30% drop in reimbursements, right? So people need to do a little bit more in order to sort of maintain the ability to sort of pay for facilities, pay for machines, pay for this, pay for that. And so all these little ways that AI can improve efficiency are going to help so that you don't sacrifice on the other end, right? The most important thing to not sacrifice is the time evaluating the images or evaluating the patient. That in no way, shape, or form can take a reduction in time. But if I can save time because the measurement was already made, or things were already labeled, or it popped everything into my report, that is going to translate into better patient care because you will be able to have increased workflows. You'll be able to expedite care without sacrificing any of the quality. And that's where I hope AI is going to go. So I see some of it already. In fact, AI does something kind of interesting. It can actually take your findings and make a impression for you, which is nice. So once you dictate all your findings, you click into your little impression section, right? It just kind of gives all the points. So it'll be like, full thickness rotator cuff tear, bursitis, whatever, whatever. It does that based on all of your findings in your report. It also saves time. So those things I think are part of the future. Long term, is going to be that wearable device, the sleeve that you put on, like an elbow sleeve to check for elbow pain, or a shoulder sleeve, something like that, or even a shirt, right? Like how awesome would that be if I just put on my athletic shirt and I'm like doing some exercise and it'll tell you you're straining, your common extensor tendon a little too much. You need to drop your weight for 5 pounds. I mean, that's way in the future, but I could see my grandkids, you know, playing sports where they were wearing wearable shirts and shorts and knee pads and things, which gave them real-time information on how hard they were working, how hard their tendons were working, whether they could push it a little bit more, whether they need to back off. All of that is kind of it seems crazy right now, but based on the technology, I could totally see that being a part of, all of our activities. And I can actually see that also as we age, right? So that it can prevent falls and injuries, right? Because you don't really want these, falls account for a huge number of catastrophic injuries to our, elderly patients. And, if we can prevent that maybe with these things by telling, alerting them like, oh, you're ambulating a little off, or you need to do this, you need to do that, or you know what, we know we need to strengthen this person's quads a little bit more because that'll help with their ability to ambulate on their own. Little things like that are going to make a huge difference. So wearable would be awesome once we get to that point. But integrated into my clothing would be the dream. But you got to dream big, right?
Test patient one. Test patient
The
one.
best quote I ever heard was that your dreams have to be greater than your current ability to do them, right? And so that's kind of the dream, and I think it's something feasible in the future.
Yeah.
So.
Yeah. No, I think those are really good points. I think, you hit the nail on the head with AI. AI for me in medical it's not taking away our specialty. It's allowing us to focus on our specialty. When I talk to sonographers, the actual scanning is only 5% of what they do. There's pulling up the histories and, surveying the patient and taking care of the patient and documenting and, what can we, to your point, streamline? Yeah, I can hit those annotation buttons real quick, but what if I didn't have to hit them? What if I didn't have to draw a cursor to draw a measurement? But we're also human. So there are some AI technologies out there right now in our breast realm that alert us to, hey, this doesn't look like everything else. Like we looked at everything and this doesn't look like everything else. So it's not telling you what it is, but it's that second barrier because we are human beings and the volumes are increasing and the patients are getting, harder to scan. And so it's that second kind of defense mechanism. And I don't see AI taking over, at least, for us here in the US, taking over anything. I just see it making us focus on, what we all went into this realm to do, which is, take care of our patients and healthcare to the best of our abilities. But I think it's the technology that's really, really on the cusp of something pretty phenomenal. I don't know that I want to see the price tag associated with those things. Because that scares me if you're saying your grandkids, which means like my kids wouldn't be that far behind. I don't got money for that. I don't got money for
Yeah.
college, let alone that. But no, I think those are interesting points. When we talk about professional athletes, can we look at the routes? Are we drawing up plays with routes that are requiring foot movements that are putting our athletes, in risk? And yeah, we can put them all in green suits right now, but that still has cords and that still has
Hmm.
limits. And they don't necessarily run that route the exact same way. Can we, in the moment of the game with the pressures and things coming upon them, can we survey those plays and those routes we're asking them to run and try to eliminate it? And same with kind of ergonomics. We look at ergonomics now, but can that information from something like that give us even better information about ergonomics in terms of not just what we do, but just our daily lives? How ergonomic is our car? You say De Quervins. I got it from driving because I'm
Oh
that lame.
no.
I'm that lame. Got it from driving because I always drove with my right hand, these two
Mm.
fingers. But yeah, to that point, are we making, vehicles? Are we making, household utensils, things like that? What's the ergonomics behind them? And that could give us the information, which, is pretty exciting. So,
It's exciting.
all right. Well, thank you so much. I think we're at the hour, but thank you so much for your time. That was an amazing conversation as always. Now you have my brain churning. I'm going to go call my engineers. I'll give you credit. Don't worry. But I'm just going to go increase my wish list that they already have posted into their desk. So thank you so much for joining us and have a great day.
You too, and thanks so much for having me. It's always a pleasure doing all of these things with you, whether it be like a hands-on course or the GE course or whatever it may be. It's always a pleasure talking to you. So thanks so much for having me.
Yeah, thanks.
Talk to you later.